Good morning, everybody, and welcome to this CREMS webinar today. It's fantastic to have you all with us, and I think we'll have a really interesting session for you. My name's Louise Birrell. I'm a postdoctoral research fellow here at the National Drug and Alcohol Research Centre, and in a moment I'll introduce our speakers for today. But before I do, I just wanted to draw your attention to the CREMS webinar series and let you know about an upcoming webinar that we have in July, focused on psychosis and the mental health effects of ICE. And also direct you to our past webinars, which you can watch on demand. So I just want to tell you a bit about what CREMS is for those of you who might be joining us for the first time. So CREMS stands for the NHMRC Centre of Research Excellence in Mental Health and Substance Use. And what CREMS is about is conducting research to improve our understanding of mental health and substance use disorders across the areas of epidemiology, prevention and treatment, and so that we can have improved strategies and to conduct research to identify the most effective ways to prevent and treat these conditions. So to achieve these aims, we work really closely with services, schools and community groups, and this webinar series is one of the ways that we help foster these lines of communication. So here you can see a photo of our team, including our youngest members down the front there, and the centre is led by our director, Professor Marie Thiessen, who's an NHMRC Principal Fellow at the National Drug and Alcohol Research Centre and was most recently awarded a Companion of the Order of Australia in recognition of her work. So Marie has made a major contribution to Australia's health and medical research efforts in the field of mental and substance use disorders. And in particular, she's known nationally and internationally for her research on the comorbidity between mental and substance use disorders. So it's now my absolute pleasure to introduce our speakers for today. We have two speakers today presenting on post-traumatic stress disorders and substance use, promising new treatments for adults and adolescents. So firstly, Associate Professor Katherine Mills will be presenting first. She's working here at the National Drug and Alcohol Research Centre and has been with us since 2001. She's an NHMRC Senior Research Fellow and Director of the Treatment Stream of Research at CREMS. And her research focuses on the epidemiology and treatment of co-occurring mental and substance use disorders, in particular post-traumatic stress disorder. So Associate Professor Mills has published widely in the area and has been an investigator on grants of up to $10 million and has received a number of awards of excellence in science and research in recognition of the impact of her work in the community. So we're really lucky to have Kath with us today. Joining Kath is Dr. Natalie Peach, who's joined us this year as a postdoctoral research fellow at the centre, and she's currently working as project coordinator on the COPE-A clinical trial, which you'll hear more about today, which is investigating the efficacy of integrated exposure-based therapy for co-occurring post-traumatic stress disorder and substance use disorder in adolescents. And she's recently completed a combined master's and PhD in clinical psychology at the University of Melbourne and Oregon Youth Health, with her PhD focusing on the relationships between childhood trauma, PTSD symptoms and psychotic symptoms in young people with early psychosis. So we're in really good hands today, and I think we're going to hear about some exciting research. So I'll now hand over to Associate Professor Mills. We'll then come back together at the end for questions. So if you do have any questions, please feel free to type them in as we go, and we'll have an opportunity to have some discussion at the end. So thank you, Kath.
Thanks very much, Lou. And good morning, welcome, and thank you to everyone who's joining us on our webinar this morning. Today, we've split it into two parts. So I'll start off by giving a bit of an introduction or background to what trauma and post-traumatic stress disorder are and how common they are in people with substance use disorders, and also a bit about why we're so concerned about the high co-occurrence of this disorder. And then I'll talk a bit about why it is that PTSD and substance use disorder tend to co-occur, and how a bit about how the symptoms interact as well. Then I'll switch over to Natalie, who will tell us a bit about what the evidence is at the moment about how we best treat this comorbidity in both adults and adolescents. And as Lou mentioned, Nat will also touch on an exciting new trial, which we're just starting recruitment for, looking at integrated treatment of traumatic stress and substance use in adolescents. So, trauma. According to the most recent edition of the Diagnostic and Statistical Manual of Mental Disorders, a traumatic event is where a person is exposed to either death, threatened death, actual or threatened serious injury, or actual or threatened sexual violence. So basically any sort of event where a person feels that their life or their safety or the life and safety of someone else is at risk. And so that events can be experienced either directly, where you're personally experiencing it. You could witness an event happening. People may also experience a traumatic event indirectly in hearing about something that's happened to someone close to them. But there can also be other indirect exposures through a person's job where they're continually exposed to the details of traumatic events. And traumatic events can be either a one-off, for example, like car accidents, workplace accidents, or natural disasters, or they might be something that's more prolonged, for example, in the case of prolonged childhood sexual abuse or domestic violence. And post-traumatic stress disorder, or PTSD, is the most common psychiatric disorder that can develop after someone has experienced a traumatic event. And there's four main groupings of symptoms that people experience. The first is symptoms of intrusion or re-experiencing, where the person continues to have involuntary and disturbing and intrusive thoughts about what happened to them. They might have nightmares about it or flashbacks where they feel like they're reliving the experience. They're back there again. They typically try to avoid people, places, activities, situations, thoughts, feelings, basically anything that will remind them of the event. Have alterations in their physiological arousal and reactivity, in that they're constantly on edge, always on the lookout for danger, hypervigilant, and sometimes irritable or aggressive. And with all of those things, it makes sense that they also have difficulty concentrating and perhaps problems sleeping. And a relatively new addition of symptoms to the diagnosis of PTSD are negative alterations in cognitions and mood. So where a person has persistent negative thoughts about themselves or the world around them, excessive self-blame, or also some of the symptoms that are perhaps more reminiscent of depressive disorders, like diminished interest in activities that they used to enjoy before a trauma, and difficulty experiencing positive emotions. Many people will experience these symptoms after they've experienced a traumatic event. They're a normal reaction to an adverse event. But for most people, the symptoms will start to subside over a period of a month or so. But for some people, 1 in 10 who've experienced a trauma will go on to develop a post-traumatic stress disorder where those symptoms are continuing. And basically, it can be sort of conceptualized as an adaptive response to fear that's become maladaptive. So many of these symptoms are actually useful and serve a function if your life is in danger or you're at risk. But in the case of PTSD, it's when that response has become maladaptive and you're starting to trigger even in situations where perhaps, are very objectively safe. And in Australia, upwards of 80% of people entering treatment for alcohol or other drug use report having experienced a trauma. So almost everybody who's walking through the door. The most common types of traumas that people report are witnessing serious injury or death, having been threatened with a weapon or held captive or kidnapped, or physical or sexual assaults. But you can see on the right hand of the slide, there are some other examples of events that people commonly report. So there are many and varied, but the vast majority of people have experienced multiple traumas. And there are also very high rates of trauma that's occurred in childhood before the age of 16. Given the high prevalence of trauma exposure, I guess it's not particularly surprising that there are also high rates of PTSD, with up to 2/3 of alcohol and other drug clients in Australia screening positive for post-traumatic stress disorder when they come into treatment. And at the moment, the evidence suggests that there's not a lot of variation across the different types of substance use disorders, but there is some evidence to suggest that perhaps sedative, opioid or stimulant or amphetamine type use disorders are more strongly related to a co-occurring PTSD diagnosis. But just also by way of comparison, the population prevalence in Australia of current PTSD in the last 12 months is only about 4.4% and 2.5% in the last month. So incredibly high rates of PTSD among this population of people who are seeking treatment for their substance use. But it's also important to recognise that there are many other comorbidities that clients often present with, which may have come about as a consequence of trauma. And there's also increasingly been a push towards recognition of the concept of complex PTSD to perhaps better reflect the diversity of presentations and impacts across a number of functional domains. And indeed, the next edition of the International Classification of Diseases, ICD, will include a diagnosis of complex PTSD. But regardless of whether or not someone develops PTSD or any other mental health disorders in response to a trauma, those events are often life-changing, defining moments for a person, whether they're a one-off, whether they're prolonged. It can really redefine a person's view about themselves, the world around them, and how they relate to that. Which is why we really do need this trauma-informed care approach across our alcohol and other drug services and all health services, really. And having that knowledge about a client's trauma history is really critical to be able to understand how it is that the person has come to be in this particular situation that they're in today, and informing what the treatment approach will be to help them. Coming back to a diagnosis of PTSD, though, in people with substance use disorders, we know that PTSD in this population group tends to be severe, but very few access treatment, less than a third. And also that the PTSD typically has an early age of onset and the substance use. For example, Nat will talk about one of the trials that we conducted in adults looking at treatment for co-occurring substance use and PTSD, in which we found that the average age of onset for first trauma exposure was 8 years old. And 3/4 reported experiencing trauma before the age of 16. Now we'll talk about that a bit more. And also studies have found among adolescent groups with a substance use disorder, about 70% have experienced trauma, so also very high rates, and about 35% also have a concurrent diagnosis of post-traumatic stress disorder. If we look at it the other way, among adolescents with a diagnosis of PTSD, about half of those will also have a co-occurring diagnosis of a substance use disorder. So not just substance use, but use to the extent that it's become problematic and they've actually met criteria for what has previously been categorised as abuse or dependence. And some examples of factors that may predispose particular children or adolescents to developing PTSD after a substance use disorder can be insecure attachment styles, internal attributions of blame, or avoidant coping strategies. But irrespective of whether or not those risk factors are there, the ability of an adolescent to cope with a trauma, or child at that time, is tenuous because they've yet to fully develop their cognitive, social and emotional capacities, and also have less stable social supports, perhaps. So because of the substantial sort of biological, social, neurological and psychological changes that are occurring during this critical developmental period, it's a time when people are particularly vulnerable to the impact of a trauma. because it's when you're developing the foundation for how you'll communicate, how you'll engage in interpersonal relationships, you're establishing your own identity and increasing self-awareness, trying to seek independence and establish self-efficacy, and also learning how to regulate your own emotions. So if a person experiences a trauma during this critical period, it is associated with that increased risk for developing serious and disruptive problems that can persist into adulthood. So difficulties across a number of domains, as I mentioned, emotional regulation, their interpersonal functioning, cognition and memory. And this can play out in the sense of lower educational attainment or unemployment, engaging in high-risk behaviours or aggression, chronic physical and health conditions, in addition to the mental health and substance use disorders. And given the breadth of those problems, it makes sense that these adolescents tend to, and young adults, present across a range of health services and social services, but typically don't receive the treatment they need to address their underlying trauma or PTSD. So typically they don't actually present to treatment for their substance use disorder or PTSD until they do reach adulthood. By this time, there is very well entrenched poor physical health, mental health, and psychosocial functioning. So when they're presenting to treatment, they're presenting with a far more severe clinical profile and also demonstrating poorer treatment outcomes across those domains. So why is it that both PTSD and substance use disorders co-occur so commonly? The predominant and hypothesis in that which has the most evidence to date is the self-medication hypothesis, where it's thought a substance use disorder can develop as a consequence of repeated substance use in an effort to ameliorate those symptoms of PTSD that a person has. And it seems that self-medication not only can play a significant role in the development of substance use disorder, but also in the maintenance of that disorder. And in support of that, many studies have found that around 50% of people who develop a substance use disorder have their, in about 50% of cases where there is co-occurring PTSD and substance use disorder, the trauma and the PTSD symptoms predate the onset of the substance use disorder. But there are other theories as well. The high-risk hypothesis that the lifestyle associated with substance use disorders, particularly illicit substance use disorders, places a person at increased risk of experiencing a trauma, so they're more likely to develop PTSD. But it's also thought that people with substance use disorders might also be more susceptible to developing PTSD after they've experienced a trauma, either because they lack those coping skills to deal with the trauma when it happens, but also that they might be biologically susceptible, in that they might be predisposed because of the dysregulation in their stress response system because of the cycles of repeated cycles of intoxication and withdrawal. And lastly, it could be that there are common factors that are underlying both conditions that lead to their co-occurrence, or the interaction of those kind of things like biological, psychological, sociological factors. But regardless of how these disorders come to co-occur, once both have been established, they both serve to maintain and exacerbate each other. They are integrally related. If a person has improvements in their PTSD symptoms, either in response to treatment or just spontaneously, we know that there are subsequent improvements in a person's substance use. But the reciprocal relationship is not as strong. Even if a person is able to achieve significant reductions in their substance use, there's often no change in PTSD symptoms. Actually, not just no change, but there's actually, on the contrary, PTSD symptoms may worsen. So what people often find is that they'll perhaps reduce their substance use or stop using, that their PTSD symptoms will start to increase again, which doesn't lend itself to maintained abstinence or reduced use and places people at increased risk of relapse. So all of these factors collectively really highlight why it is so important that we do try to address the trauma PTSD among clients who have PTSD and substance use disorders. But understandably, clinicians commonly report that they find it really challenging to treat this comorbidity, which makes complete sense. These are often long-term, well-entrenched problems, more severe clinical profile. But also there's been the problem that there really hasn't been a great deal of research to provide some sort of guidance to clinicians about what is the best approach. How can we best treat these co-occurring conditions? Fortunately, though, even though there hasn't been that much evidence, this has started to change over the last decade. And so I'll now switch over to Nat, who will talk to you a bit more about that evidence and what we know so far about how to best treat co-occurring PTSD and substance use disorders. Thanks, Nat.
Okay. Okay. Hopefully that's all okay. Thanks, Kath. So how do we best treat co-occurring PTSD and substance use disorders? So traditionally, there's been a bit of a reluctance among clinicians to treat PTSD in substance-using clients. So clinicians often have concerns that these clients might be too vulnerable and won't be able to cope with some of the stress that is evoked by PTSD treatments. And there's also been a common belief that you need to first treat the alcohol or drug use before addressing the PTSD in these clients. And that the client would need to maintain a level of reduced use or abstinence for a period of time before being able to have therapy for their PTSD. But as Kath mentioned just before, often when people stop or reduce their substance use, their PTSD symptoms can increase. So stopping the substance use can be very difficult to achieve. And often these clients end up being passed between different services and receiving very little coordination of care. So of these three models over on the right here, the treatment models for PTSD and substance use, what I just mentioned was the first model, the sequential model, where substance use disorders are treated first and then at a later time PTSD gets treated. The middle model, the parallel model, is where the substance use disorder and PTSD would be treated at the same time, but by two different clinicians, which isn't very often done. But then the third model down the bottom, the integrated model, is the one that clients and clinicians both indicate that they prefer, where the substance use and the PTSD symptoms are treated at the same time by the same clinician. So there have been a number of integrated psychological therapies that have been developed for treating comorbid substance use disorders and PTSD over the last couple of decades. And these approaches can be divided into two general types. So the non-trauma focused therapies or the present focused therapies. So these are the therapies where the therapist deals with issues that the person is having in the present that may or may not be consequences of the past trauma. And these therapies don't involve discussing or revisiting the trauma in any level of detail. So the most well-researched of this type of therapy to date is the Seeking Safety program, and the website's just there. The second type of therapy are the trauma-focused therapy or the past-focused therapies. And these require that the person goes back to address what happened to them at the time of the trauma through repeated exposure or repeated reliving of the event. So exposure to memories of the trauma or reminders of the trauma and what happened to them. So that's an approach called prolonged exposure. So a recent Cochrane review found that there's relatively little evidence to support non-trauma or present-focused individual or group-based therapies, but that there's the individual trauma-focused therapies that are delivered alongside substance use treatment can reduce PTSD severity as well as substance use. So most of the therapies that are past-focused use some level of exposure. So they're called exposure-based therapies, which are currently the gold standard psychotherapy for PTSD. And traditionally, exposure-based therapies have been considered inappropriate for people with substance use disorders for some of the reasons that I mentioned before. So concerns about the client experiencing distressing emotions that might be overwhelming for them, which could put them at risk for other things. So maybe increased substance use or higher risk of self-harm or suicide. And another concern has been that because prolonged or exposure-based therapies are cognitive therapy, there are worries about the client's ability to be able to engage in the cognitive task due to possible impairment that they may have due to repeated or long-term substance use. But researchers have started investigating the efficacy of integrated exposure-based programs that address PTSD and substance use issues simultaneously. And support for these programs is growing with an increasing number of studies showing evidence for their safety and efficacy. So there have been 2 large randomized control trials done, both of them in Australia. The first one by Sanabali and her colleagues here at the National Drug and Alcohol Research Centre compared the efficacy of integrated CBT for PTSD and alcohol use with CBT for alcohol use plus supportive counselling. So those were the 2 groups. And participants who received at least 1 session of exposure therapy had clinically significant change of about twice the rate in terms of their PTSD severity compared to those who received the CBT for alcohol use and supportive counselling. And so then around the same time, there was another randomized control trial done here at NDARC, led by Kath and her colleagues. So this trial examined the efficacy of an integrated therapy called concurrent treatment for PTSD and substance use disorders using prolonged exposure, or COPE therapy. So this was with individuals who had a range of substance use disorders, and COPE therapy combines CBT for substance use disorders and PTSD and includes prolonged exposure. And that was compared to treatment as usual for substance use disorders condition. So this is just some information about the participants in that trial. And as you can see, this was a very severe clinical sample. So about 75% of the sample had experienced childhood trauma, so their trauma before the age of 16, and the median age of their first trauma was 8 years old, as Kath mentioned earlier. More than half of the sample had experienced childhood sexual abuse, which is the most common trauma reported, and they had been experiencing their PTSD symptoms for an average of about 10 years. They also had high rates of other concurrent disorders, so major depressive disorder, anxiety disorders, borderline personality disorder, and there was quite a high rate of attempted suicide in this group as well. They also had high levels of dependence and used a range of drug classes, mainly heroin, cannabis, and amphetamines. So despite that severe clinical profile, it was found that people who had received the COPE therapy and those who had the treatment as usual for substance use experienced improvements in their substance use, the severity of their dependence, their PTSD symptoms, depression and anxiety. So they didn't get any worse. There wasn't any evidence to support previous concerns that I mentioned about clients potentially worsening with this type of therapy. And then participants who were randomized to the COPE therapy had significantly greater improvements in relation to their PTSD symptoms. And so these differences were considered to be clinically significant. And you can see here that there was a parallel reduction in severity of the substance use disorder that came along with reduction in PTSD symptom severity. So at baseline in this trial, 100% of the sample had PTSD diagnoses in both the treatment and the control groups. And then at follow-up, close to half of them had lost their PTSD diagnosis in the COPE group, compared with about 20% who lost their diagnosis in the control group. So one important point is that about 75% of people who are randomized to receive the COPE therapy continue to use substances throughout the study. And this shows that while substance use might impede the therapy, it's not actually necessary to achieve abstinence before the commencement of PTSD treatment. So improvements can still be obtained even with continued substance use. They just might not improve as quickly. And then it's also important to note that changes in PTSD severity were not influenced by the presence of other comorbidities, so depression, anxiety, borderline personality disorder, or by types of traumas experienced or the types and number of the substances that were used. So in terms of participant feedback for the program, it was very positive overall. Some people described it as the best thing that they had done for themselves in a long time. And many people hadn't realized how much their trauma history was linked to their addiction. So for a lot of people, it was the first time they'd ever really talked about their trauma before, which is important because often people don't talk about their trauma unless someone asks about it. And we also know that clinicians can be quite reluctant to ask clients about their trauma. And in particular, people said that the exposure-based components of the therapy, where the clients revisited memories of their trauma, were the hardest part, but were also the most useful part of the therapy. So there were also some follow-up analyses done in this study to see if there were particular client or treatment characteristics associated with change in PTSD severity. And it was found that people with higher PTSD severity at baseline had more improvement, and more sessions attended were associated with more improvement as well. And then more traumas experienced prior to baseline was associated with less improvement. So that points to a possibility that maybe a lengthier treatment might be required to address those multiple traumas. And then this provides further evidence just for COPE therapy being safe and applicable to a broad range of clients who have PTSD and substance use disorders. So the COPE treatment manual is published in the Oxford University Press Treatments That Work series and is available online, and it also comes with a client workbook as well. So since Kath and her colleagues conducted that trial, there's been some further research done specifically looking at the COPE treatment. So there's been a pilot study done among women in Sweden that has showed significant reductions across all of their outcomes, including PTSD and depression symptom severity, alcohol use, craving, and dependence. And then another study with community members in New York compared the efficacy of cope and relapse prevention therapy for substance use relative to an active monitoring control group. And so both of the groups demonstrated greater reductions in PTSD and substance use compared to the active monitoring. And then participants who had full PTSD diagnoses, as opposed to sub-threshold diagnoses, had significantly greater reductions with the cope therapy relative to the relapse prevention therapy. And then another study done in the US looked at the efficacy of cope compared with treatment as usual among military veterans, and the outcomes of that study will be published shortly. So other than cope, there's a range of other trauma-focused therapies that are out there, and studies looking at these have also largely shown that there's evidence that they lead to improvements in PTSD symptoms and substance use disorder severity. So these studies have all been done with adults, but there's somewhat less research that's been done among adolescents, which is something that we really need in light of the things that Kath was talking about earlier. So most people with these co-occurring disorders have start having problems in their adolescent years. So there has been one protocol paper and 4 pilot studies done so far. One of the studies includes a component of gradual exposure. So among the pilot studies, there's one looking at CBT-based coping skills therapy. So that's the Seeking Safety program that I mentioned before. There's a mindfulness-based cognitive therapy one, and also family-based multi-systemic therapy with gradual exposure. So these have showed some promise, but it's still quite preliminary research, and we still don't know what works for adolescents particularly. So this has led to the current trial that's being done by Kath and her colleague, being led by Kath and her colleagues, looking at concurrent treatment for PTSD and substance use using prolonged exposure among adolescents, so the COPE-A study. And this is an adaptation of the adult program that was done. So it's been adapted to meet the developmental needs of adolescents, and it incorporates the evidence base regarding the most effective treatments for PTSD and substance use among adolescents into a 16-session therapy program, which is being compared to a supportive counselling control. So we're currently recruiting for this trial from the Greater Sydney region, and I've just put our inclusion criteria up there. So we're looking for young people who are between 12 and 18 years old, who have had lifetime exposure to at least one traumatic event, who have full or sub-threshold PTSD diagnosis, and have used alcohol or other drugs in the past month, and have a history of problematic use, and are also fluent in English. So both treatments, the COPE-A and the supportive counselling groups, will receive 16 sessions with a psychologist, one-on-one. And then there are also 4 optional caregiver sessions. So the client can nominate a caregiver who is then welcome to attend 4 sessions with the same psychologist that the client themselves is seeing. So these sessions are going to be provided free of charge, and participants in the study can continue seeing their current clinician while they're participating in the trial if they wish. So there's just some contact details up there for anyone who might want to get in touch about this study and refer any clients or young people. I'll put that back up in a second, but I'll just do a quick summary of what we've talked about today. So trauma exposure and PTSD and substance use disorders commonly co-occur, and they're associated with significant harm and poorer treatment outcomes. But there is some hope. There's growing evidence that demonstrates the safety and efficacy of trauma-focused treatments. And participants in these studies didn't demonstrate worsening of their symptoms or high rates of relapse. They actually demonstrated improvements in both their alcohol or other drug use and PTSD symptoms as well. So then the challenge going forward is really looking at how we incorporate these evidence-based treatments into practice and move from trauma-informed care also to trauma-focused care as well. So I'll just stick that slide up again, and then, yeah, that's all from me. Thank you. So, yeah, anyone with questions, please feel free to ask us.
Thank you, Nat and Kath. That was an excellent presentation, and I'm sure everybody's gotten a lot out of that today. So I'd encourage you to write in any questions that you have to ask either Nat or Kath while we have them here with us, and we can have a bit of a discussion. We have had a few come in through the presentation, which I might start with, and these are in relation to COPE-A specifically. So the first question that's come in was asking what exactly was the dose of the exposure therapy that people went through in the COPE-A program.
Sorry, Lou, did you say the COPE adult program or the adolescent one that we're just starting?
Sorry, I should have been clearer. The COPE program that you've covered before, but it might also be interesting to talk about the COPE-A program too, if you know that as well.
Yeah, Nat, are you happy for me to answer that one?
Yes.
Cool. So for the adult COPE program, the whole program was about 13 sessions, and it wasn't really until sessions 5 or 6 that we started to introduce the exposure-based components. Prior to that, it was sort of focused on psychoeducation and building skills so that people could perhaps cope with the exposure-based tasks a bit better without automatically going back to substance use. But since then, based on our study and then some of those other studies that have been conducted since, the exposure-based components have been brought forward. So now someone would typically start around session 4 for the COPE adult treatment. And and that's the same for what we'll be doing in the COPE adolescent trial, is starting earlier. The reason being is that is one of the, or what is hypothesised, and from other literature that's PTSD based, we know that these are the elements of the treatment that are likely to do or give people the most benefit. So we want to try and get those in as soon as we can, so that they're starting to feel the benefits of that treatment earlier.
Yeah, excellent. That makes sense. And another question that came in relation to the COPE adult program, did you notice any variation in outcome for people depending on the social situation of the client? So I'm not sure if this is something that you looked at, but specifically whether clients who are homeless or less connected with family had different outcomes?
No, we didn't. It's a really good question, though. And definitely the literature more broadly supports that that social connectedness and having that social support is one of the strongest predictors of whether or not you are going to either develop PTSD or recover from PTSD. In the COPE trial, we certainly had a lot of variation in that, but maybe slightly more towards the more disconnected people who didn't have a lot of social support. But there were also people in there that did have quite still close family relationships and trusted friends.
Yep. Yeah, great. And we've had somebody ask where they can access the COPE therapy manual, whether that's available to purchase online or in stores. And on top of that, whether the COPE-A treatment is covered in the COPE adult manual.
Sorry, Nat, do you want to grab that one? I'm hogging the...
Oh, no, that's okay. So the COPE manual is available for purchase online. That's right, isn't it, Kath?
Yes, yep.
Yes. Okay, just checking. But that will have the content that is just pertaining to the adults. So there isn't the manual out yet for the adolescent COPE therapy. But hopefully that would be coming along in coming years.
Watch this space.
Yeah, we'll see what the results are. if it's found to be something that's efficacious, then we would be looking to do that.
Yeah, great. And so that's currently recruiting at the moment. Is that just in Sydney?
Yes, that is. It's just in Sydney, sort of in the greater Sydney region. So, yes.
Great. So if there are people watching in the Sydney area or greater Sydney region who are interested in taking part, the best idea would be to get in touch with either Nat or Kath through the contact details.
Yeah, so contact details up there, and on the website, you can go to the website and it links to a subscription page. So if you'd like to put in any details there, one of us on the study team can get in touch with you.
Yep, fantastic.
Sorry, can I just add something to that, Lou, if that's all right? Also, we're trying to reduce as much as possible the logistical barriers for adolescents to be able to attend. So we're happy to travel out to locations that are convenient to them to deliver the therapies.
Excellent. I'm sure many people will be happy to hear that. And what are your thoughts about in the future the potential for COPE-A to be delivered by practitioners other than psychologists, as someone said, for example, youth workers?
Definitely. At the moment, all of the trials of the COPE adult have been have been delivered by either sort of masters or doctoral level psychologists, and mostly clinical psychologists. So that's why at the moment we're still sort of recommending that's who can deliver the treatment. But quite honestly, with the right training, I think that other clinicians, other experienced clinicians with the right training in CBT for substance use and PTSD could deliver this treatment. Is that your thoughts as well, Nat? Or?
Yeah, definitely.
Yep, great. And just in the question on the content of the COPE protocol, does the exposure include systematic desensitization to reduce re-experiencing trauma in its protocol?
The two parts of exposure that are in it, one is the imaginal exposure, where the person is in session with their therapist, repeatedly recounting and being exposed to their memories of the trauma. And one of the mechanisms by which that's thought to work is this habituation to the anxiety experience that eventually decreases. The other part is the in vivo exposure or real life exposures, where a person is exposed to reminders of the event that are causing them problems in the world. So ones that are actually impairing their functioning and are objectively safe to do. And that is a gradual process of building them up to more and more anxiety-provoking situations.
Yep. Okay, excellent. And going back maybe to the beginning of the presentation, this question's come through asking whether you would consider trauma to be the same as multiple incidents of PTSD. So both terms have been used interchangeably, this person asks. Is there a difference between complex trauma and PTSD?
I think there have definitely been, there's been that push to really try and get that recognition for a form of the complex PTSD that the evidence to date so far shows that perhaps more accurately reflects the breadth of disturbance in functioning and disorganization of self, and how people relate both to themselves and to the world around them and their relationships. Then they tend to be, those symptoms tend to be more related to the prolonged and early and multiple traumas that a person might experience. It's taken a while for the momentum to really recognise that this is the clinical picture for these people, but it is now going to be recognised in ICD. The American Psychiatric Association DSM-5 committees, though, didn't consider there to be enough evidence at this point to include it there, but I think we will see a lot more research into it, perhaps providing some support of it now that it's in ICD.
Mm-hmm. Yeah, it's an interesting question and area to watch for the future. And a comment and a question that's come through. So this question has said that one of the potential issues with delivering COPE-A with adolescents in primary healthcare might be a limit of 10 to 12 sessions on the MBS. And have you considered this in developing the program, potentially thinking about an adaptation to fewer sessions? Could this be done? And if so, how? Maybe Nat, do you have any thoughts about that?
That might be a question for Kath, I'm thinking.
Sure.
If you don't mind answering it.
I'm always happy to talk. Yes, we did. And it's always that kind of balance between when we're developing or trialling newer therapies and figuring out, okay, is this something that can, if it was successful, be translated into practice? And, we struggle with this to an extent, but feel that ultimately we need to go with what does the science tell us about what is needed and how long is that going to take us to deliver? And then hopefully that sort of evidence can then serve to inform about how many treatment sessions governments will fund for people to get rebates on, to be able to take into account that it doesn't just take, 10 sessions to cure everyone's lifetime problems. But it's also possible. I mean, this is, for the adolescents, it is a 16-session program. It's possible that many won't want 16 sessions. There could be some who are finishing much earlier, and that's something that we will be looking at and reporting back as well, like how much benefit can we get if it is like within that 10-session framework. But I think we do need the evidence that perhaps challenges as well the current rebate systems and how long it takes to treat people.
Yeah. And in the adolescent program, how long does each session last for at a minimum? And is this any different to the adult COPE?
So there's 60 to 90-minute sessions in the adolescent version of COPE, which I think was the same in the adult version, wasn't it, Kath?
Yes.
Okay, excellent. And a couple of questions have come in about this topic, and people are wondering whether there's been any differences in outcomes, so in relation to COPE, the adult version, dependent on gender. Do you see any different responses for males or females?
No. Same response. We did look at that as one factor to see whether it would or wouldn't be any different, but no. And that's sort of consistent with the broader trauma literature as well.
Mm-hmm.
Thankfully.
Yeah. Yep, really engaged. Excellent. I know we've been bombarding you with questions, so just a final few before we run out of time, but we've got lots flooding in, which is fantastic. So somebody's asked whether clients who worsened or increased their alcohol or other drug use, were there any clients who worsened or increased their alcohol or other drug use during the exposure phase of COPE? So any potential risks to be aware of in different stages of the therapy and protocol?
Mm-hmm. We were absolutely expecting that to be the case, that there would be some instances. Particularly one of the things that we know from the exposure-based treatments and others, though, is that sometimes symptoms get worse before they get better. But for that reason as well, knowing that that's coming, we had really prepared the clients for what they were going to be experiencing during that time, that there was a possibility that they would become quite distressed a bit more, have their symptoms elevated, but working with them then about what strategies they might be able to use to cope with that other than their, well-entrenched sort of fallback of going to drinking or using drugs to try and cope with those emotions. And I think that worked really well, people having that high level of preparation for what was going to come. And by that point, sometimes people were sort of saying it wasn't as bad as we thought it was going to be. You'd prepared us for something, quite terrible, but it wasn't as bad. It wasn't nice, but it wasn't as bad. And so no, we might have had, there were, I think, a few people where there was a little bit of an elevation, but not like a full relapse, more lapse type situations that they're able to pick up on very quickly and work with us with. But I think as well the important thing the whole way through the treatment with this was making sure that people didn't think that a lapse was the end of the world, and that that sort of catastrophizing and thinking you're going back to the beginning, because they're not. Also, we had a look as well about whether or not there was clinically reliable change across the COPE cohort, and in those who were randomised to receive COPE, much higher rates, sorry, I can't remember them off the top of my head, of reliable and clinically meaningful change in PTSD symptoms, and that was quite a significant shift. Higher rates of no change, no clinically significant reliable change in the control group, and then we had nobody worsening, demonstrating a clinically significant worsening in symptoms in the COPE group, but we did have people in the control group that were experiencing a worsening over time.
Yeah, interesting. And in the trial, were there any measure of different types of outcomes dependent on the type of trauma, and whether this program was successful or not based on trauma type?
Yeah, no, there wasn't. So, I mean, bearing in mind that it is a relatively small sample that we were able to analyse that with, only sort of 50 participants. But we did look at all the different trauma types that people are experiencing and the ones that they endorsed as perhaps being their worst events, and there was no difference in outcomes based on those traumas, except for what Nat had mentioned about those who had experienced a greater number of traumas had lower levels of improvements, which makes us think that perhaps they do need more time in treatment to be able to address all of those issues.
Yeah, great. And Nat, I'm going to throw this one out to you, see if you know anything on this. Somebody's asked whether you're aware of any evidence for art therapy being used in the treatment of PTSD or substance use, so if there's any research evidence out there looking at art therapy.
I'm actually not sure about the evidence base in that particular area. Sorry. Kath, sorry, just throw that back to Kath.
No, that's all right. I mean, there is increasing research in, I guess, not just art therapy, but also other creative ways of expressing what a person has been through with their trauma as well, mostly coming out of the United States. I can't remember off the top of my head exactly what the evidence is saying. So take this, I guess, with a grain of salt. Have to look it up for more details. I think, though, the evidence is looking promising from what I know, and there are certainly a number of services that are integrating that as part of their treatment for PTSD.
Yeah, great. And final question. So you mentioned that trauma-focused therapies and those therapies which involve exposure in particular are more effective than present-centered therapies. But what do you do if a person doesn't want to do that kind of therapy?
Nat, did you want that one or me?
I might let you finish on that one.
No worries. Yeah, honestly, and that's completely reasonable. Not, as for every kind of treatment, we need a multitude of different treatment types. Not one thing is going to work for everyone, or people won't want to do it. In these cases, I would definitely suggest having a look at the present-centered therapies that might be more appealing to those people. And it's sort of those present-centered therapies are also thought to be perhaps like an introduction, in the sense that they are, I don't know, people might have had a look at Judith Herman's work on the sort of the stages of recovery from trauma, and the first stage is about seeking safety and becoming safe before somebody goes on to go to do the second stage, which is the sort of exposure-based and revisiting what is actually, and confronting what has actually happened to you. So I think absolutely, starting with the present-centered therapies like seeking safety, which can be delivered one-on-one or in group formats, and in that way, sometimes that makes it more appealing to certain alcohol and other drug services that have to run group programs and can't perhaps have the funds to do as much one-on-one therapy. And then it is also possible that the person will then want to move to doing the exposure-based stuff once they feel safe and have maybe a greater sense of self-efficacy to be able to do that.
Yeah, excellent. Well, thank you both very much. It's been an excellent session today, and thank you to all of those with your questions flooding in. I apologise if we didn't get to all of them today, but we do need to let Nat and Kath go and have some morning tea and get on with their day. So I'd like to thank them both for an excellent session today, and thank you all for attending. We will have future webinars coming up on the CREMS webinar training site, so please check back there and register for the next webinars. Thank you, everybody. Have a lovely day. Goodbye.
Thanks, everyone. Thanks, Lou.
Thank you.